Hello, everyone. Welcome to this session organized by FIP on reflux management in the community. So I would like to welcome you all to this event. As you know, we have a couple of members or attendees on the waiting room. We're now approving all of them to join us. We also know by experience that we have some participants that will join us a bit later, but that's okay. Anyway, with no further ado, in the next slide, while I'm presenting myself, my name is Luís Lourenço. I'm a community pharmacist from Portugal, a practicing community pharmacist, and I'm also the professional secretary of FIP. And as I mentioned previously, it's an honor to be here today moderating this event. On our next slide, you will see a couple of announcements. The webinar will be recorded and live stream via YouTube, as you usually do as well. For FIP members, the recording will be available at the website that is mentioned here, events.fip.org. During the running of this webinar, if you'd like to ask any questions, feel free to use the Q&A box provided. It'll be easier to deal with all the questions there instead of the chat box, because some of the questions can actually be answered during the presentation as well. Please let us know what you thought about this webinar, although we'll also send a form afterwards to get your feedback. But anyway, please let us know what are your thoughts about this webinar, what you like to see in the future as well covered on the FIP webinars. And for those of you who are no members of FIP yet, I always like to mention yet because it's a good value for proposition, feel also free to join us on fip.org/membership_registration, so you can become an individual member of FIP and have access to all our materials and other activities that we organized. Now, on our next slide, you will see all our participants for today's event. I'll have the opportunity to shortly present them prior to their presentation. Two of the speakers, Polly and Peter, actually have sent their videos, and we'll go through them a bit later. As you can see on the next slide, we'll have them both after Ruben, who I will present shortly as well, and then we'll have Anna Zorko and Kai Zanyap to share their thoughts on their specific topics, and then we'll have time for Q&A, for question and answers. We'll try to cover some of the questions that are being put on the box, so feel free to actually use it during the presentation, and then at the end I'll do a small wrap-up to all of you. And just to remind you as well that this has been recorded, so with no further ado, we'll move forward to our next slide. Oh, sorry, I was almost forgetting about the limited objectives of this event. So this idea is to share about what FIP has developed on this specific topic, reflux management, and also the main therapeutic options to support relief of reflux-like symptoms, and to learn a little bit about the pharmacist's perspectives on this specific topic. So next, I have the opportunity to give the floor to Ruben Viegas, who's right now the FIP Practice Development and Transformation Process Coordinator. Although he's based on the headquarters is based on the Netherlands, Ruben is actually on the other side of the world. But I'll give the floor to Ruben so he can share some thoughts about resources from FIP on reflux management. Ruben, the floor is yours. Thank you.
Thank you so much, Luís, for this kind introduction. It's a pleasure to be here in this FIP digital event, showcasing the resources that FIP produces, because there's many of them, and we need to share them, and we need people to be able to access them. So my presentation will not be long, but I want to start mentioning that FIP has a specific microsite, a specific web page focusing on self-care. And you can access this through the QR code or the link. So it's prevention.fip.org. And then we have three different areas. We have vaccination, self-care, and vector-borne diseases. But for this project and for this area of work, you can go and see the self-care page. And inside the self-care page, you'll have all the publications that we've been developing in the last years, all the events and webinars on specific topics, some partnerships that we have, and also some external resources from other organizations. What I like to think is that self-care is a bit like a Pandora box. So we have a lot of topics that can be covered in this area. And for today, we have reflux management that, together with other minor ailments, are very common in the pharmacies. I worked for 2 to 3 years in pharmacies in Portugal and in Spain. So I accumulated some experiences in this area, that a lot of patients came to the pharmacy to solve their issues, their problems, their minor ailments, and reflux and gastrointestinal disorders were for sure among the most common ones, especially in specific times of the year. For example, in Portugal and Spain, after Christmas, we would have a lot of reflux cases, for example. Moving forward, I want to present one of the resources that it's available for members only. So as Luis said, you can get the membership for FIP, and you can see the added value also through the access for some resources that are specific for members. And this was an international insight board. So it's a focus group methodology that captures different ideas and different issues around the world, so around different countries, how they manage the reflux symptoms. So it's a very brief publication, but it has very good insights from different perspectives. Because even from between Portugal and Spain, it's quite similar, the culture, but you can still find some differences in how you approach and which type of advice, or even which type of medicines people use, for example, as first line. So this is a resource that you'll be able to access on a member-only basis. And today we're launching a new resource. So it's a quick reference guide. And what's great about the quick reference guide is it's very short. It's a very easy to read publication. It has different blocks, as I will present later. And you can easily see the different blocks, and it's very visual. So you can also have all the information in a visual way to have a clear overview of this topic. Of course, it's not very comprehensive because it's a quick guide, but still provides some ideas and some basic topics for this specific topic, that is reflux, that we bring here today. And this one is open access, so you'll be able to access through the FIP library. And if you get the FIP mailings, the link will be there. I apologize, I didn't include it here. But you'll see it also on Facebook and LinkedIn. You'll see a post with this publication. A quick thank you for Rekit for supporting this publication through unrestricted funds. So thank you so much. And the publication that we're launching today has a table of contents, is short introduction that we use for most publications to set the scene. And then we have 6 different blocks. So the causes of reflux symptoms, the patient's experiences, so the symptoms themselves, the triaging aspect, pharmacological management, and non-pharmacological management, because these usually go together, but they're exactly not the same. And then in the end, some links, some resources that pharmacists can access, because there's already much done in all areas. So we should also link the work together to other organizations and other associations. And you can see that there's 2 videos included. The 2 videos included in the publication are the ones that will be presented today. So you'll be able to see them here in this recording. But if you click and access the publication, you'll also be able to see them. And of course, in the end, there are the references that we usually include in also all the publications, because they need to be evidence-based. So I'll just get a quick overview of the different blocks. I'll not spoil the reading of the publication. For example, on the causes, we have this visual aspect that focuses some main points. So bad nutritional habits, as I mentioned before, especially over Christmas, that if we celebrate Christmas or any other holiday, major day, festivity, you'll eat for sure too much with different foods, some greasy foods. So these nutritional habits might be the cause for the reflux, because we have too much food in our stomach. Excess weight is also linked to reflux symptoms, especially because of the physiological changes that our body has in our digestive system. Smoking is another important factor. Older age, it's because the body as well will change with time and will have also a change in our digestive system. Physical inactivity. Nowadays we have more and more sedentary lifestyles, and this is also not helping the reflux to happen. Certain medicines can also cause reflux, and some mental health conditions that are connected. So, for example, people with more anxiety might be more likely to develop symptoms. So this is all then more detailed, but at least we have a big overview of the main causes of reflux symptoms, most of them linked to the lifestyle changes. Focusing a little bit on the experience or the symptoms, we have different ones. I'll not go through all of them, but the most common ones is like this sensation that you can see, heartburn. We have this feeling of food. We have this, it feels heavy on the throat. Then we can have also problems swallowing or coughing associated to it. If it's a bit worse, my mom is always vomiting from time to time, and I tell her, you need to treat this symptom because you're having a lot of reflux, and that's why you're even vomiting. And then you can also have a sore throat because the acid is going around on this area and can also irritate the throat area. We included a box also with red flag symptoms because in these cases it's important to do the referral to the general practitioner or to other place in the health system where patient can have a follow-up and can understand if they need an exam or any other type of treatment that is not available in pharmacy. So if we have a lot of difficulty in swallowing or pain, bleeding, if the unintentional weight loss, so if the person is losing weight in a specific rate, anemia or any masses, so these are all symptoms that should lead to referral. So that probably in a pharmacy with non-prescription medicines would be hard to manage, and these need further investigation. So if you see a patient with any of these flags, normally it's a very good idea to refer them to the healthcare system. The chapter about triaging focuses most on the questions because if you're working in a pharmacy, you probably have hundreds of patients every day, depending on how busy it is. And then it's very hard to have all the questions for all the areas in your head. So it's always good to go and look a bit on the different questions that you can have for the specific aspect of reflux. So you can ask, does it burn above your stomach? Sometimes it was good to ask, can you point me where it burns? Because sometimes it was not really the esophagus, it was more on the side, for example. If it feels worse when you eat too much, so you can associate that with the food. For how long, which other symptoms you have, are you taking any other medicines that you can see? We know that then they have an interaction with this. And also if the person has nausea, vomiting. So these small questions that then trigger the conversation, but they're important to understand if the person is really having these symptoms and characterize a bit the symptoms so we can know what to do next. Do we provide advice? Do we give a non-prescription medicine? Do we refer? So it's very important to do this small triaging in every encounter that we have with patients. Another chapter focuses on the main pharmacological management options. So we have the antacids, very well known. They're very short intermediate relief, so they neutralize the acid. Very good for these festivities. We had a lot of people looking for them. Then the alginates, sometimes they go in combinations as well. So they form a gel and coats the stomach, so it protects it a little bit, tries to provide a barrier, so provides some relief there. Antihistamines H2, which are maybe not widely used, surely not as the proton pump inhibitors, the PPIs, that are probably more widely available everywhere. and in most countries they might be available as a non-prescription over-the-counter medicine that can be advised in specific situations. So an important note is that the PPIs should be used at the lowest effective dose for the shortest possible time, because there might be situations where people just take PPIs for the entire life when there's no need for such approach. Sometimes there might be a need if a physician, a prescription, if that person is prescribed with this treatment, but sometimes people just take them after a treatment and they don't stop, or they don't have the proper recommendation to use the PPIs. So this chapter focuses a bit on the pharmacological options, the main ones, of course. Then there could be some more specific cases where we have different ones. And almost last but not least, the non-pharmacological aspects, because we saw on the causes that most of them are linked to the lifestyle. So it's important to provide advice on managing a healthier lifestyle, eating smaller meals, avoiding spicy, acidic, greasy foods, high-fat foods, which is probably the normal tendency right away. We just get takeaway. It's probably not as healthy as if we cook at home, but it's probably cheaper, or we don't have time, so we just go with these options. The fluids, they're a bit better between and not during the meals, so we don't have a large volume in our stomach. The lying down or going to bed, so it links with the elevating the head. So if you have reflux or symptoms, especially at nighttime, it can be a good idea to elevate, put a couple of pillows below your head and your chest, so that the reflux doesn't have the help of the gravity to go back to our mouths. And the aspect of avoiding eating before exercise could be also, because when we're exercising, we're contracting a lot of muscles, so it can be also a cause for reflux. These are not less important than the pharmacological ones, because it is indeed effective. If you put these in place, we'll probably have a lot less cases of reflux. The last aspect, the last chapter, it's about some tips and resources. And last year we published a self-care handbook, more comprehensive publication, where we had these flowcharts, and we decided to include them here again, because it's a very visual way. So a person enters the pharmacy, what are the causes? Can we provide already direct advice, because we know this was a one-time case, or there's a specific cause to it. If not, we assess the symptoms with the questioning. If there's a red flag, we refer. If not, we can do a management of the complaints. We can also think about the Helicobacter pylori, which can sometimes be present. It's not very common, but this would need also to be referred, and the tests would need to be done in the healthcare system. And then we have the pharmacological and non-pharmacological advice that can be given to that person. So this is kind of a consultation roadmap. So the person enters, we talk to them, which is something we already do in the pharmacy every day, but in a flowchart. And there's also some links in the publication that can also be accessed for further information, further scientific studies, because self-care is a Pandora box, but then inside each topic there's research and more developments as we go. So there's been a lot of reflux development in the last years, and the next videos the professors will also showcase these aspects and this part of constantly needing more scientific evidence. So if you have any questions, please drop them in the Q&A box. And I think, Luis, that's it from my side. I hope you enjoyed, and I hope you become FIP member soon.
Thank you so much, Ruben. Really excited about this new resource published by FIP, this quick reference guide for reflux management. And thank you as well for sharing all the chapters and go through them a little bit in detail, and specifically on therapeutics. I will kindly ask you if you could go to the Q&A. There are a couple of questions over there. They might be able to answer them directly so our participants get the proper information. And now, as Ruben has mentioned and has been referred as well on the program from this event, we move forward with the program, and we're going to have two video presentations for two expert members. The first one will be from Professor Peter Karillas. I'll always try not to misspell this. So Dr. Peter is a gastroenterologist in Michigan, Illinois, and is affiliated with Northwestern's Memorial Hospital. He received his medical degree from the University of Rochester School of Medicine and Dentistry and has been in practice for more than 20 years. As a specialist gastroenterologist, he has advanced expertise on diverse digestive disorders such as stomach pain, ulcers, reflux, constipation, and Crohn's disease. I kindly ask to move forward with the next slide so I can have the opportunity to have Dr. Peter's video. Thank you.
Good afternoon, or morning for me. I'm Peter Karillas, coming to you from Chicago, and I'd like to briefly discuss the latest developments on the cause of symptomatic reflux. So with respect to the management of initial mild to moderate reflux-like symptoms, and I would emphasize that most are mild to moderate, this should really focus on lifestyle modifications, weight loss, and the as-needed use of antacids or alginate, reserving endoscopy for patients who have alarm features such as bleeding, dysphagia, or weight loss. And that will usually work and is usually a sustainable approach. So in most instances, no diagnostics are necessary, and one simply addresses reflux-like symptoms. However, they don't always work, and sometimes there's clearly a failure to respond to this pragmatic approach. In those instances, one adds acid inhibition. Now, one approach to addressing reflux-like symptoms has been described as the ladder approach to reflux management, where one first addresses lifestyle issues and then adds a PPI, then adjusts the PPI in terms of timing, doubles the dose or splits the dose, increases the dose, switches to a different PPI, switches to a PCAB, and only after all that has failed goes to the non-acid blocking options or investigation. But there are some major problems with the latter approach to treating reflux-like symptoms. Gastric acid is the only target of this therapy. So it has led to an awful lot of long-term PPI use and high-dose PPI use, which in turn has led to intensive scrutiny of potential associated adverse events. And it's based on the Montreal construct, which assumes that reflux-like symptoms share the same pathophysiology as reflux esophagitis and the same dose-response characteristics to treatment. But this just isn't true. Each reflux phenotype has unique pathophysiology, and the only phenotype with a clear dose-response curve to acid inhibition is reflux esophagitis. The latter approach ignores the reality of the brain-gut interactions, and brain-gut interactions are very important. So, looking at these different syndromes, from Barrett's all the way to functional heartburn, you get a shift from demonstrable altered physiology to mainly or entirely altered perception. Now, when there's altered physiology, the modulating or predisposing factors are obesity, hiatus hernia, diet, and habits, and objective testing with endoscopy, pH metry, etc., can be quite useful. With altered perception, however, the modulating or predisposing factors here are IBS, dyspepsia, anxiety, depression, hypersensitivity, hypervigilance, somatization, insomnia, and fear. And non-PPI treatments are going to be more effective than acid inhibition. So behavioral medicine consults, neuromodulators, alternative medicines or even mucosal protectants in some cases. So again, there seem to be behavioral as well as physiological determinants of symptoms. And that's evident in this prospective cohort study of 105 patients with pH impedance, dividing them into the three Rome-4 groups of NERD, reflux hypersensitivity, or functional heartburn. In terms of acid exposure time, this is, of course, how they're divided up. The NERD patients are abnormal at almost 9%. The other two groups are normal, and that's statistically significant. With reflux events, very abnormal in the NERD group, practically normal in the reflux hypersensitivity and functional heartburn group, using 40 as the upper limit of normal there. Mean nocturnal baseline impedance, you can show a difference. So the NERD group have subendoscopic mucosal damage, whereas the reflux hypersensitivity and functional heartburn groups are pretty normal. But the GERD-Q, which is an estimate of the severity of reflux symptoms as perceived by the patient, no significant difference between the three groups. And in terms of the EHAS, which is the Esophageal Hypervigilance and Anxiety Scale, there's no difference between the three groups. So the only thing that correlates with the perception of symptom severity is the EHAS score. Furthermore, although Rome-4 went to great lengths to distinguish reflux hypersensitivity from functional heartburn, there's absolutely no difference between these two by any of these metrics. So where does this leave us with the frontline management of reflux-like symptoms? Well, emphasize the importance of lifestyle and behavioral modifications. This amounts to encouraging weight loss, dietary modifications, adjust eating and sleeping patterns, use targeted therapy with PRN, antacids, and alginates, or H2 blockers instead of open-ended PPI therapy. Use psychometric tools or psychological assessment, such as the EHAS tool, the Esophageal Hypervigilance and Anxiety Scale, early on to identify the perceptual drivers of symptoms. Be pragmatic about PPI use. Establish the need. Use diagnostic testing such as endoscopy and manometry selectively to tailor therapy and exclude alternative diagnoses that have alternative treatments. And that's the key. Alternative treatments. This amounts to high-grade esophagitis, motor disorders, and EOE. These are mainly patients with dysphagia. Breakthrough or persistent symptoms stem from some combination of reflux, hypersensitivity, hypervigilance, psychiatric comorbidities, and misdiagnosis. These rarely respond to the latter approach of escalating acid inhibition. Address brain-gut dysfunction with cognitive behavioral therapy and neuromodulators, and do this early on. Thank you for your attention.
So, well, I can send a thank you, at least from distance, to Dr. Peter, but it's time to move forward with our next presentation from Pali Ungin, who's Emeritus Professor of General Practice, Newcastle University, and he was the founding Dean of Medicine at Durban University, and he's also the President of BMA in 2017. He's a GP for over 30 years and has expertise of all both primary and secondary care, with a clinical research career across healthcare boundaries. So I will ask just to move to the next slide so you can hear the video from Pali.
Hello, my name is Pali Hanjin, and I'm the Emeritus Professor of Primary Care and General Practice at the University of Newcastle upon Tyne in the United Kingdom. I'd like to say a few words about upper gastrointestinal symptoms, particularly symptoms which are thought to be related to gastroesophageal reflux, symptoms which have been characterized in the past as being GERD, which is gastroesophageal reflux disease. Upper gastrointestinal symptoms are extremely common worldwide, and the prevalence has been put at between 20 to 40%. I'd be very surprised if anyone watching this video has not experienced heartburn, indigestion, or regurgitation symptoms at some stage. The prevalence of these symptoms is rising quite quickly. We don't quite understand why. Perhaps it's because we are learning to characterize them more, but also because of changes in lifestyle, changes in diet, perhaps a more sedentary approach to life, as well as, of course, the fact that the world over there appears to be an epidemic of obesity, certainly weight gain, not only in Western countries, but elsewhere also. Over the last few years, primary care doctors as well as pharmacists have been consulted all over the world by people with upper GI symptoms and reflux-like symptoms. Reflux-like symptoms can be characterized as a feeling of regurgitation of food or stomach contents towards the esophagus, or some form of discomfort, which in many Western countries is called heartburn. Over the last few years, as a result of some influential working parties and because of wonderful advances in the management of these problems, the proton pump inhibitors have become quite important. With the proton pump inhibitors, the PPIs are the mainstay of managing these symptoms in many parts of the world. And in fact, in many parts of the world, you can buy the PPIs over the counter without having to consult a doctor. And this is where the role of the pharmacist comes in quite strongly. Having said that, and having said how important PPIs are in dealing with reflux symptoms, particularly when there is proven esophagitis, by that I mean an inflammation of the lower esophagus, normally found on gastroscopy, we know that the PPIs are excellent for dealing with established inflammation and esophagitis in people with these symptoms. The difficulty arises in people who don't necessarily respond either fully or not at all to these PPIs. Our assumption quite often is that reflux and reflux-like symptoms are due to acid problems. But of course, excessive acid is really quite an uncommon condition. There is the Zollinger-Ellison syndrome in which you get hypersecretion of acid, but that's a rare condition. And it is not acid alone that causes these symptoms. Stomach contents, including powerful enzymes such as pepsin, can reflux into the esophagus. In addition to that, there's a whole range of functional problems of the upper GI tract, including those from the esophagus, which can cause these symptoms. So that in these people, acid suppression is not necessarily going to be the answer. Trying to find out and trying to delineate between those people who need proton pump inhibitors to suppress their acid, and trying to figure out which people are not likely to respond to PPIs and might need a different approach is quite a challenging question. Of course, in the ideal world, we would not develop these symptoms. We would eat more sensibly, not gain so much weight, and obey certain rules in terms of avoiding fluids before going to bed and so on. But at the same time, we have to admit that we're all only human. People with these symptoms are going to persist for a long time. So what alternative strategies can we use? What alternative strategies can we think of? There are, of course, a number of important rules to follow. Someone with a new onset of symptoms, particularly in the older age group, needs to be investigated. In countries where there is a higher prevalence of ulcer disease, people need to be tested for Helicobacter pylori and considered for eradication. In many instances, people may need a gastroscopy. But let's assume that someone has had all these tests and then still suffering from these symptoms. That is a group of people which interests me particularly. And as a general practitioner, working with my pharmacy colleagues, I see this group of people as a massive challenge. How are we going to approach their symptoms if the PPIs are not working? In fact, data indicate that only a relatively small proportion of people with upper GI symptoms will respond to PPIs in the longer run. In spite of that, we actually have huge numbers of people taking PPIs, possibly 5 or even 10% of the population in some countries. And of course, their rather indiscriminate use has led to confusion about their effectiveness in particular settings. So what I'd like to do, if we are given the chance to work with colleagues, is to discuss alternative strategies, as well as PPIs, of course, as to how we can treat these rather difficult, awkward conditions, which present frequently both to the pharmacist and to the general practitioner. Thank you.
Very interesting insights shared by Pali. So yeah, we are actually, I think that all of us, even from our professional life or even from our personal life, just got some sort of connection for what has been shared, and this interesting perspective that we have a huge use of PPIs, but probably they are not being used adequately. So that's one of the things I'm actually going to cover during the next couple of presentations, and then we'll have a chance, as I mentioned, to go through the Q&As. And with no further ado, I'll just give the floor to Anna Zofko, who's going to speak on the community pharmacist's role in reflux management, key reflections. And so Anna, she graduated from the Faculty of Pharmacy and Biochemistry of the University of Zagreb. And in 2021, she completed the postgraduate specialist study in clinical pharmacy at the same university in Zagreb. She's a member of the board of directors of the Chamber of Masters of Pharmacy and a member of the CPS Exco. So Anna, thank you so much for taking your time. The floor is yours.
Thank you for the introduction. I would like also thank you for the invitation and the opportunity to participate. It's a great pleasure to be able to listen to you and also to have opportunity to talk about our experience. First slide, please. Next one. The group patients that we most often encounter in our work are pregnant women, also children, working population, and elderly age 65 plus. As for the guidelines, they are very similar across all age groups, and this is due to mechanism of this disease, which is pretty much the same. The mechanism of disease is shown on the right side of the slide, and I will not dwell on its explanation now. I will just mention the most common causes that we see in practice that cause reflux. Those are obesity, stress, alcohol consumption, consumption of certain drugs, smoking, etc. So reflux is one of the most common disease of the modern man and the most common disease of the upper digestive system. Next slide, please. So the goals of the treatment are primarily to relieve the patient of the symptoms, which will certainly lead to improvement of his quality of life. Furthermore, our goal is to prevent the complication that reflux can lead to, and the complications are numerous, from ulcers, perforations, bleeding, and even cancer. Also, our goal is to prevent recurrence of reflux. Next slide. So according to the report of the Agency of Medicines of Bosnia and Herzegovina, the consumption of medicines for the treatment of the alimentary tract and is in the second place. So they take about 16% of the total consumption of medicines, which is really high. So therefore, it's very important that we know the guidelines, interaction, side effects, and the risk and benefits of the long-term use of these drugs. That's why I'm glad once again to be able to talk about this topic and also to listen to all of your lectures. Next slide. Management reflux in a pregnancy. So reflux in a pregnancy is very common due to hormonal changes and shifts in the body, especially in the third trimester of pregnancy. So studies show that more than half of all pregnant women experience severe heartburn. So the first line treatment is change in a lifestyle. If there is no improvement, we include OTC preparations, alginites, which have a high safety profile and which can also be combined with PPIs. There are also antacids with calcium and magnesium carbonate, simethicone, and probiotics are something where we have a very good experience. Most often we give Lactobacillus rhamnosus strain, and taking it on an empty stomach gives us excellent results. Antacid with aluminium we avoid in a pregnancy woman. And the third line is the inclusion antagonist H2 receptors, most frequently famotidine and PPIs. We usually use pantoprazole, which we although have as a OTC preparation, we never give them to the pregnant woman without a doctor recommendation. As for the lifestyle habits, as Ruben mentioned, we advise eat healthy, more frequent, smaller meals, drink fluid between meals, eat slowly, avoid spicy fried fatty food, and also avoid caffeine and of course alcohol, and quitting smoking. We also advise an upright position when feeding and slightly elevated position when sleeping, putting a pillow under the shoulders because it's the way we prevent the return acid from the stomach into esophagus. Next slide, please. Management reflux in children. I have to admit that we rarely see children with reflux in our practice. We only had a few cases of obese children and children with asthma who also had a GERD. So I'll just run through this slide. Physicians are guided by the up-to-date guidelines shown on the left side of the slide, which include lifestyle changes, PPR inclusion. For the kids, they usually prescribe omeprazole and esomeprazole for long-term use, and antagonist H2 receptors for a quick relief of symptoms, and there's most common famotidine. We also give OTC preparations, alginites, and combination of herbs that are allowed to use in children. So they can be used independently, but they can also be combined with PPIs. One of the links that we have seen in the practice is long-term cough and GERD in children. We have such research from 2006 in Croatia, where the connection between chronic cough and the GERD in children was monitored, and it was determined that cough is significantly associated with acidic GERD, and that younger children have a higher risk to have a combination of these two diseases. You have a link to this research at the slide, so who is interested can look. Next slide, please. As we can see from the title of this slide, the prevalence of development of the reflux disease is 10%, and the most common cause is Western lifestyle. The working population is actually our most common patients with this type disease. The first intervention we do is a consultation about their lifestyle habits that can contribute to reduce symptoms, and also recommendation OTC preparation they can that you can see at this slide. And if the condition does not improve, the second line treatments are PPIs and antagonist H2 receptors, which we give just for a short time use. And if the patients do not improve, we send them to the doctor, and the most common recommendations is PPIs in 4 to 8 weeks, and where the most patients feel a significant improvement. What we often see in practice is connection between asthma and GERD. Up to 80% of adults with asthma have some form of GERD, which can very often be a trigger for an asthmatic attack. And also people who have poorly controlled asthma have more frequent symptoms of reflux. In addition to these guidelines, I would like to mention stress as one of the most common causes of the reflux. Therefore, in addition to mention preparation in a treatment on reflux, we give melatonin, valeriana, magnesium. So this preparation will help our patients to reduce the stress and to improve their sleep, and due to that they improve their reflux symptoms. Next slide, please. And when we talk about use of drugs for the treatment of reflux in elderly, it's very important to take into account the numerous comorbidities and the possibility interactions of these drugs. In fact, research shows that people over 60 years use an average 5 to 7 drugs in a chronic therapy. So this is about polypharmacy, but there is also polypragmacy, which is inappropriate prescribing of a large number of medicines to elderly people. It represents a great risk for the occurrence of many interactions and of unwanted actions. Studies show that the most successful intervention is optimization of prescribed therapy. So guidelines for the treatments of reflux in elderly are the same as in the working population, but the most commonly used drug is pantoprazole. In addition to being used to the reflux, it's actually used for gastroprotection in this population. And a very common interaction that we see in practice is clopidogrel and pantoprazole, also pantoprazole and the preparation with iron, where pantoprazole can reduce antithrombotic effect of clopidogrel and also can reduce absorption of iron. So then there is an interaction with pantoprazole with food. Patients, due to many medicines that they use, they don't know when to take which medicines. So it's very important that we make them dosage table, which we often do in a practice. And when they have that dosage table, they are more adherent, and ultimately they achieve better treatment outcomes, which is actually our goal. Next slide, please. And finally, I would like to present a couple of interesting cases from our practice. First case is patients who had frequent sore throats and was often prescribed an antibiotic, clarithromycin. And patient had to miss his work 7 to 10 days with each illness. Due to planning an operation, a detailed examination revealed reflux, which our patient did not mention to the otolaryngologist because our patient considered that irrelevant in a given situation. Anyway, by prescribing therapy, PPIs, changing lifestyles, our patients' repeated inflammations of pharynx have decreased and disappeared over time. So here's an interesting example of how the reflux can be cause of the other disease and where PPIs have done a lot of good. Our second case, long-term and I would say unjustified use of PPIs can have a negative consequences. An interesting case is our patient who had diagnosed with rheumatoid arthritis and who in the acute phase of disease took a high dose of non-steroid anti-inflammatory drugs and also, of course, corticosteroids, and was prescribed PPI a long time with them. But after her arthritis condition improved, and after all her prescribed medication was stopped, she was not informed to stop take PPI. She continued to take it because she said, I wanted to protect my stomach. So after a while, she began to feel weak, exhausted, and she came to our pharmacy for advice. And she was thinking to take some multivitamins. And in the conversation with her, we found out that she uses PPI, in our opinion, unjustifiably. So we sent her to the doctor with proposal to stop taking PPR and to perform a vitaminogram. And after the analysis, deficiency of vitamin D and vitamin B12 was determined. And here we assume that the long-term use of PPI and suppression of gastric acid secretion caused the malabsorption of these vitamins and consequently fatigue. And at the very end of the presentation, I would like to present one of the conclusions of my final specialist work. By analyzing the prescribed therapies for about 100 treated patients at the internal department of the Mostar Clinical Hospital, I found that about 70% of them used PPIs for purpose of gastroprotection. And it's interesting that about 40% of them developed Clostridium difficile infection during hospitalization. This is also an interesting piece of information, considering that continuous use of PPIs is associated with higher frequency of Clostridium infection. So that would be the end of my presentation. I would like to thank you for attention, and I hope I didn't exceed the allotted time too much. Luz, back to you.
Thank you so much, Anna. Perfect timing. And thank you so much for sharing your expertise and your investigation as well results. Very much looking forward to see if there is any question from our audience. And then we move forward to our last presentation from today, will be run by Dr. Yap, who teaches minor ailments therapeutics, clinical reasoning, and patient care skills in the B.Pharm curriculum at the National University in Singapore. Her research interests include medication use appropriateness in older patients, community-based pharmaceutical care services, medication adherence, and the use of serious game in pharmacy education. Kai, the floor is yours. Thank you so much.
Thank you so much for the kind introduction, Louis. Good morning, good afternoon, and evening to everyone, wherever you are tuning in from. Hello from Singapore. I'm very honored and very humbled to have the opportunity to be sharing on this platform with fellow community pharmacists all over the world. I think FIP has done a great job in summarizing the resources pertaining to reflux symptom management and leading on from the informative sharing by all the previous speakers. I wish to use this opportunity to explore with everyone on what are some of the ideas that we can consider in order to ensure the effectiveness and safety of how we manage reflux symptoms within community pharmacists, as well as our roles as community pharmacists. I wish to use this slide to start the basis of the discussion. And I think we would all agree that the role of pharmacists is in identifying and resolving drug-related problems within the care relationship of trust and mutual respect with patients, and supporting the patients in maintaining what matters most to them. And this underlying philosophy basically drives a standard patient care process that may involve data collection, assessing on the data collected in order to arrive at a care plan, and then implementing the plan with patients through patient counseling and education, and ending with follow-up. I will be using this as a starting point to think about how we also can extend the philosophy of pharmaceutical care as well as the standardized care process within how we manage reflux conditions in minor ailment management at the community pharmacies. So when responding to patients' complaints, I think first and foremost, we usually start with gathering of information. the main things that we want to ask patients about probably pertain to their main reasons for coming to see us at the pharmacy, followed by a history of the presenting illness, as well as what they may expect from the consultation. And leading on from the assessment of what they tell us and what we ask, we therefore will come to a conclusion about what their problems may be. And these sometimes may include a suspected new medical problems such as gastroesophageal reflux disease, or maybe it is some other medical conditions that may be presented with similar symptoms as GERD or reflux problem. Sometimes we may find that these symptoms that patients communicate to us may be related to a problem of a medication that they are existingly on, or it could be relating to a worsening or complications of an existing problem. And with this, we would then be able to arrive at the relevant care plan, which sometimes may require referral for the patients to be further investigated for proper diagnosis and treatment. We may also need to think about opportunity in optimizing patients' existing medication treatment in order to resolve any medication-related problem that could be identified, as well as sometimes prescribing OTC products or lifestyle modification in order to help relieve patients' symptoms. And after this, thought process going on, we will then need to communicate with our patients, and through the communications, we may be discussing or helping our patients in understanding the disease and treatment, how they would need to use medicines appropriately when they get home, and encourage lifestyle modification, and perhaps to understand when they need to seek further help. And lastly, to be able to follow up with patients in order to track their outcomes and revise their care as appropriate. I think one of the main challenge that I find is that sometimes patients do not necessarily present with one medical problem. And I think especially in receiving inquiries from patients, they may come presented in a variety of typical and atypical symptoms relating to reflux. And the atypical symptoms may be pertaining to complaints such as having chest pain or chest discomfort, chronic cough or throat irritation that may also be symptoms relating to other medical conditions in the cardiovascular system, respiratory system, or maybe musculoskeletal system as well. And I think the challenge is that it can be quite unnerving when triaging patients who also have existing metabolic conditions, perhaps not well managed, who come to the counter and say they have chest discomfort. Yeah, and I think the challenge also comes in because as pharmacists, we are not sufficiently trained in the area of clinical reasoning pertaining to diagnosis. And so it may be a challenge to really think about ruling in and ruling out to see whether or not it is a case of angina versus it is a case of a reflux symptoms arising in relation to dietary issues. I think another challenge coming in is in the form of barriers in pharmacist-patient communication. Specifically, sometimes patients don't necessarily know how to describe their symptoms. For example, the chest discomfort may be burning in nature, but they could present and communicate it as having chest pain, and that adds on to the complication of how we need to be able to identify if it is truly a reflux symptom, or there could be an underlying angina issue that really needs our attention and for quick and urgent referral, or to point to the patients to seek further investigations in order to really ensure their safety instead of just sending them home. Another issue coming in is with regards to patient familiarity and expectations to their own symptoms and treatment that they are familiar with. And a lot of times patients come in telling us that they've got a sore throat and they're looking for lozenges, but they do not realize that it is actually a ill-managed reflux issue that has led to maybe throat irritation or dysphagia and the likes of it. And I think that's really challenging for pharmacists to be able to identify what the underlying etiology and the underlying medical problem is in the midst of self-reporting by patients and perhaps preferences for self-medications. And patients often do so without seeking an appropriate diagnosis or endoscopy for objective investigations to be done. More complications come in that makes it really challenging for us as community pharmacists is in the form of really advocating for lifestyle modification. As you have heard from the previous speakers, there are many risk factors that leads to reflux symptoms and maybe gastroesophageal reflux disease. And these include smoking, tobacco use, alcohol, maybe obesity with the need for weight management. I think the challenge in really us providing effective intervention is in the fact that these lifestyle modifications really require behavioral change interventions, which require a lot of time and resource to be able to speak and walk with the patient to discuss about these behavioral changes, which fortunately or unfortunately, community pharmacists normally do not have that luxury of time because we are often one person or two person in a shop and with a lot of things to take care of, and lack of reimbursement basically also means that we're short on manpower. But however, I would like to remind that it also works two ways. I think sometimes patients themselves may also feel bad about asking for more information from us. So these are, in summary, some of the challenges which I find when I was practicing as a community pharmacist, and now hearing students, preceptors also commenting on the challenges that they may have in really managing symptoms and responding to symptoms at a community pharmacy. And for the next few slides, I'd like to explore perhaps some of the ideas and suggestions for helping to overcome these challenges and for us to really start thinking about how we can have in place simple strategies or just some reminders to ensure that how we respond to patients' symptoms and inquiries, that we can be effective and safe to make sure that patients receive the best care from us. I think first and foremost, with regards to patient assessment, or rather symptoms assessment and patient triage, when it comes to reflux symptoms, recall that there's typical symptoms and there's atypical symptoms. I think it's important for us to be trained in considering possible differentials, not just to rule in to see whether or not the reflux symptoms are related to gastroesophageal reflux disease alone, but also to consider other possibilities like peptic ulcer disease, maybe cardiovascular etiology and respiratory symptoms, so that we avoid really jumping to conclusions and closing the data gathering prematurely. It's also important for us as pharmacists, because we provide pharmaceutical care, to really also consider taking medication history as part of the history taking or patient interview, no matter how busy we are, so that we can also potentially identify any medication-induced causes to the reflux symptoms, such as a chronic use of NSAIDs, inappropriate use of NSAIDs or oral corticosteroids, or lack of gastroprotectants, for example. Next is also for us to consider, identify possible contributing risk factors so that we can, in addition to providing non-pharmaceutical strategies for relieving reflux symptoms, could also contribute to getting patients to join us in the journey to quit smoking, in smoking cessation services or weight management services, and maybe to also discuss other dietary related factors that could require lifestyle modifications. And at the same time, by identifying these underlying risk factors, we could also enhance the confidence when we triage patients, or kind of rule in with verification that the symptoms that they're reporting is definitely associated with diet and therefore likely to be gastrointestinal in nature, rather than the chest discomfort or the atypical symptoms that they're reporting. If it is not related to dietary related factors, if it's related to, say, associated with exertion or associated with deep breathing, it could point us to explore other differentials in other anatomical systems like cardiovascular or respiratory systems. Next, very importantly, I think it's also important for us to be able to differentiate so that we could ask more probing questions in order for us to rule out any possible severe life-threatening differential, such as acute myocardial infarction, a possible angina that could have been undiagnosed asthma or worsening of asthma, and perhaps a mild case of pneumonia as well. I think this point came through really as one day I was walking by in the shopping mall, and I overheard a gentleman speaking to his friend saying that, oh, I've been having a lot of pain in my abdominal chest area recently, and I have hypertension, I have hyperlipidemia. I'm really wondering if I am starting to have heart problems or if it is really just a simple case of reflux. So it can be really unnerving for patients, some of the patients who have risk factors pertaining to both the gastrointestinal in terms of the reflux problems, as well as cardiovascular conditions. So I think this is a role where pharmacists could definitely come in to help to either identify what the underlying problem may be relating to and safely rule out so that we can reassure patients, or to identify a potential of other differentials going on at the same time, perhaps with reflux problem, and point the patient to possibly seek urgent medical help as soon as possible. Lastly, I think there was also a mention of red flags in the FIP materials and resources. I think that's great. And it's really important that amidst the business at the shop, we need to definitely probe for the presence of any red flags. And some of the examples are listed on the slides, which include dysphagia, pain on swallowing or difficulty swallowing, or dinophagia, melena, lactary stools, or vomiting of blood, unexplained weight loss, and anemia. These red flags possibly point to complications relating to perhaps the reflux symptoms, such as erosive esophagitis. And definitely, if these red flags are present, patients should be referred soon as possible or almost immediately for a referral for further investigations, such as endoscopy, in order to rule out any active gastrointestinal bleeding or peptic ulcer disease that may need triple therapy, or perhaps weight loss, even suggestive, unexplained weight loss, even suggestive of maybe an underlying cancer etiology. So these are some of the things that definitely has a great role of pharmacists at the front line as first responders when handling and responding to patient symptoms that we can start to think about. My next slide pertains to some of the suggestions for improving the effectiveness and safety of the care plan that we might put together for the patients after triage and symptoms assessment. And these include definitely considering referral of patients with red flags for further investigations, so that they could have appropriate diagnosis made and appropriate baseline assessment, so that with the treatment, they could properly be followed up to see the effectiveness of the outcomes of the recommended treatment. Next, I think there's a great role for pharmacists to be advocates for the use of non-pharmacological strategies and lifestyle modifications for symptom prevention. Next, I think I shan't dwell into it because the previous speakers have spoken extensively about the appropriate recommendations of OTC pharmacologicals, and these include PPIs, and of course for episodic symptom management, we could definitely consider just the use of alginate containing products or antacids, and these will basically suffice because not everyone with reflux symptoms have erosive esophagitis, which definitely would require the use of proton pump inhibitors. And I think prokinetics, it's available in Singapore, and it could be prescribed with a limited supply without a prescription. And these could sometimes be helpful for patients who have delayed gastric emptying, which could add on should PPI not be sufficient in controlling the symptoms. Yeah. Next, I think this is really a role for pharmacists in optimizing existing medication treatment. And as pointed out by the previous speaker, Anna, there were cases where patients require long-term use of NSAIDs. How can we as pharmacists start to think about ensuring that these treatments are effective and safe for patients, and therefore preventing onset of reflux problems coming on? There's a great role there for us as community pharmacists as well. Next, in helping patients understand the condition and treatment, I think this is really important because what I find in conversing with patients is that sometimes patients do not like community pharmacists asking too many questions. I think perhaps they find it very tiresome if they go to different pharmacies and different pharmacies start asking the same set of questions. I think if patients could understand where we're coming from, or why we need to assess why we are asking certain questions, and if they could understand their condition, the disease progression, why they need to manage it and prevent symptoms, it would make our role so much easier when we provide advice, and they would definitely adhere to the advice much more readily. Lastly, I think the role of pharmacists in following up with patients, no matter how simple it is, perhaps it could be just a simple phone call, could definitely help to build that rapport and keep the patients coming back to us so that we can also follow up with the patients and become their lifelong partners in healthcare. The next slide are some of the suggestions that I have that could improve the effectiveness of how we start that conversation and discussion about implementing the care plan that we have put together for the patients that we want the patients to get well with. I think demonstrating active listening skills is something that we've learned in school. Explaining reasons for questions and advice, we've explored that earlier. The use of plain language and teach back method could definitely facilitate and check patient understanding and how they will actually use the information provided. There is a great resource, I think by I can't remember the website, but if you could just type in teach back method, plain language use, I think there are many resources on the internet that could help us to start exploring how we could ask patients. I think one of the most important things when I was interacting with students about this teach back method is sometimes they often end up asking the patients to repeat what they've just said. And so the teach back method is not essentially that, it's getting patients to teach us in their own words what they're going to be doing back home. And I think that really makes the difference in helping patients to make the information actionable once they get back home, to ensure that they understood what they really need to do. And lastly, is for us to really explore the use of communication tools and techniques for encouraging behavioral changes, which could be really, really helpful in discussing smoking cessation, weight management, and dietary modifications. I think last but not least, these are some of the areas for enhancing education. I finished my entry-level education of a long time ago, and things has definitely moved forward in a lot of inclusion now that we're teaching the undergraduates, and these include clinical reasoning and patient assessment skills, which I did not have when I was in school, pertaining to symptom assessment and patient triage. I think this is a great skill to have, and that could really boost our confidence as we are speaking and triaging patients with atypical symptoms, sometimes challenging presentations, and sometimes it could be just asking the additional probing questions in order for us to be sure that we're dealing with reflux problems and not angina or any other medical problems related to other anatomical systems. Next, patient attending and communication skills, behavioral change theory and interventions, to be more familiar with that, so that we could also understand how we could engage in more persuasive communications with our patients, advocate for modification of lifestyle. And last but not least, perhaps we could just think about interprofessional collaboration, because as part of the care plan, referral definitely needs to be one of the options that we are need to discuss with patients about, and having a great interprofessional collaboration skills could definitely help us to be able to facilitate the referral of patients for help. And with this, I've come to the last slide to hopefully summarize what I have additionally added on to what we may start to think about. Firstly, definitely think about red flags that we need to refer our patients so that we can be safe in patient triage. Definitely consider other disease conditions if the reflux symptoms that they are communicating also presents with symptoms that does not really quite fit into gastroesophageal reflux disease, and for us to be able to ask pertinent questions in order to rule out underlying cardiovascular conditions that could be life-threatening, such as acute myocardial infarction and maybe a worsening of asthma a problem, and to also consider evaluating if there is underlying medication-related problems that causes the increased frequency in reflux symptoms. And in terms of care plan, in summary, definitely consider referral where needed and teach patients how to recognize symptoms or worsening of symptoms that they need to actively seek help for, not just at the pharmacy, but really to reach out for further investigation and speak to physicians, our fellow colleagues in healthcare, about their worsening symptoms. Optimizing medication treatment is definitely a role by pharmacists. And in effective patient education, to really start thinking about throwing in the other discussions, like helping patients understand the disease and treatment, helping to encourage lifestyle modification, perhaps to set up services that could address these lifestyle modifications, like smoking cessation, weight management, that could also be linked and related to our discussion about reflux management. Yeah, and lastly, if we could, to also document the interventions and what we discuss with patients about, and to check in on patients to see how they're doing. Yeah, and with that, I've come to the end of my sharing. Thank you so much for listening in, and I'm happy to take any questions.
Thank you so much, Kai, for the presentation, and I would like to say that's a wrap, because you have a lot of information, a lot of expertise, and we now open the floor for the Q&A, for the questions that have been put on the Q&A. I know that some of the questions that have been put actually on the tool have actually been answered throughout the presentations, because we know that some members joined us a bit later and then actually were able to go through some of the topics that were covered. But in the meantime, I'll give some time for our speakers to go through the Q&A, and also Ruben, since some of the questions will be raised. I'm just wondering, because there's a lot of there was a lot of emphasis about education. So what sort of education do we need? We know that community pharmacists are very busy. I think all healthcare professionals are very busy. What sort of education, from your perspective as educators, as practitioners, what sort of education needs to be prepared? Like faculty-based webinars, what sort of tools can actually be given from your own experience as a pharmacist? I will start with Anna.
We have usually we have these webinars with some topics. We didn't have a gastroesophageal reflux disease. We had something about asthma, but they are too rarely. and they should be more frequently, and we should more collaborate with the doctors. That's what we miss here in our country. So I'm trying to organize all these webinars with my colleagues, but it's very hard. We don't have a we must collaborate with the ministry, with physicians, and we're trying, but it's too little.
Okay. I will go back to the interprofessional collaboration that was actually mentioned by Kai. So Kai, from your perspective, what sort of education materials or sort of formats could be prepared or be more efficient?
Thanks, Luis, for the question. I think in terms of the interprofessional collaboration, most of the undergraduates curriculum are already starting to provide interprofessional education in the bid to foster a deeper understanding between healthcare professional students, so that we could understand each other's training and perspectives of what we focus on, so that in communicating or referring patients, it could definitely help us to speak in the same language so that we could better understand each other. And in so doing, hopefully that by the time where they enter into practicing, they could definitely have that better perspective of how they could refer patients, or perhaps to work together as a team. I think in terms of us as practicing pharmacists already, we could definitely explore ideas of reaching out to form maybe collaborative services or referral services with our fellow healthcare providers, and that could really help to increase our network and database of how we may start thinking about how to actually refer patients when we see someone with a need to be referred. These are just some thoughts, and I'm sure that with the different countries, some have already established a very good network of collaborations, maybe with their GPs or perhaps with specialists. Yeah, so these are some of the things that I'm thinking about.
Thank you so much. Thank you so much. Yeah, the topic of intercollaboration is essential, and it's cross-sectional. You not only focus on reflux, of course, also on other minor ailments, and even for chronic diseases and the intake of medicines. So thank you for your thoughts. Now we're going to go through the questions that have been actually put on the Q&A. So there's a question from Lorraine about how we can access the information, I presume, or the presentations. So I'll just like to remind you that the recording will be available at the WFIP site. So this has been done. So there's actually some question here about how does the role of proton pump inhibitors, PPIs, compare with H2 blockers and anti-axis in a pharmacotherapy of reflux. Thank you. So actually that has been covered on during the presentation. So Victor joined us a bit later, and I'll emphasize this again. If you have joined later the webinar, feel free to access the recording. So Sophia then asked, what is the recommended pharmacological treatment for the chronic cases of reflux? As has also been covered. The link for the FIP resource on GERD. So Ruben, I presume that the launch will be today, I presume? Yeah, so that's right. So beware, on the next couple of hours, you will see the resource materials or the reference guide from FIP being published. There's drugs. Oh, there's actually an interesting question from George. So what form of must the follow-up take? Visit the patient on phone call or what? Well, we would love to visit the patient, I presume, or have time for that. So I don't know, Anna, Kai, from your experience, do you have any sort of experience or information on your own countries, on your other countries about the new medicine service, for instance? This sort of follow-up, is that something common or has been discussed in some way or other? I'll start with Kai first.
Yeah, thanks for the question, George. In terms of follow-up, in Singapore, I've tried with a community pharmacy chain in setting up a service on management of allergic rhinitis, which also has a great role for community pharmacists in terms of symptom triage, really managing mild, moderate, intermittent symptoms, and then start to refer patients should they not be responsive to, say, intranasal corticosteroids that pharmacists could prescribe now in Singapore. And in so doing, I think one of the main intervention is in the follow-up with patients. And this is really essential to track how patients take to their recommended advice and treatment. And how the pharmacist did it is that we decided to go with a phone call follow-up. Something very simple and which could maybe be taken on by the consulting pharmacist who met the patients first, so that the pharmacist could also have a better idea of what was being discussed at baseline, and therefore could be mindful and clear about what are some of the outcome measures to follow up with patients on. And another way that we did it with the example of the allergic rhinitis management was that we had a dedicated kind of an intervention team where the team will review the documentations made by the consulting pharmacist at baseline, and then just do the phone call and at the same time administer some very quick, simple questionnaires in order to assess patients' symptoms, and then there and there on the spot to be able to provide some revision to the care plan and communicate back to the patient almost immediately. I think the challenge is in connecting with the patients. Sometimes they're at work and they may not really answer the phone. But I think as community pharmacists, it's really helpful because our opening hours need to cater to working adults. And if we could call after hours, that's definitely helpful from our experience from allergic rhinitis management. The other thing that we subsequently explored in version 2.0 of the intervention was that we tried WhatsApp or just messaging, and that worked well as well, but unfortunately, because of technology, not everyone is savvy, and of course, maybe different age groups have different affinity towards the different platforms. So again, I think it's really a need where you just need to explore to see what works in your own setting and with your patient population. Yeah, so that's just my experience, and hope that it's helpful.
Yeah, very much. Thank you. Thank you, Karen. So Anna, just one last thoughts.
We usually follow up our patients when they come for their medicines next month. So we talk to them about their therapy, if they have some uncommon or unwanted actions. So it's and if do they have something unusual, they come earlier. So we don't have any to call them. We don't do that, to send them messages or so. Only thing that we do is when we do a skin examination. So we have those patients, they come another month and we talk about their skin recommendations. But other patients like this disease, we do not follow them by messaging or something like that, just when they come to the pharmacy. But we should. It's a good example.
Yeah, that's why FIP is also here for, just to be able to enable everyone to know and to learn from each other. So I'm sure you will be able to stay here 1, 2, 3, 4 hours discussing this topic. But just as a wrap up, I'd just like to remind you a couple of key points that we covered during our presentations. First and foremost, of course, the launch of this quick reference guide from FIP, which was presented by Ruben. Then Dr. Peter mentioned, well, gave us a sort of historical background on the treatment of reflux symptoms. You spoke about ladder approach, the different phenotypes of reflux, which is very important to understand which phenotype we're dealing with, so we can actually adapt our strategy, the outward physiology / outward perception, the behavioral / physiological determinants, and the reflux-like symptoms. Then you move to Pali also on a video. You share with us the increasing numbers of the patients that actually mentioning having reflux symptoms, and there's still probably some relationship with lifestyle, We have covered that on most of the presentations, and the fact that many people do not respond to PPIs. Now we know why, and the fact that the excessive acids is not the only issue that is related with reflux. Then you move to Anna, which gave us an overview, more focus on pharmacy practice from her own experience as practitioner and from her research. She also focused on a couple of major areas or major patients on pregnancy, children, the working population, the elderly, and also at the end, she gave us some interesting cases from practice. And at the end, we had Kai focusing on pharmacists providing pharmaceutical care, the virtual circle of collect, assess, plan, implement, and follow up. And then she actually went on details on some of the topics, on the challenges in pharmacy-based reflux management, the typical symptoms, the insufficient training, barriers of communications. Well, there's a lot of information on that. And also she gave us some thought on the suggestions for improving effectiveness and safety of care plans, suggestions for improving effectiveness of patient pharmacist communications, and of course, some areas for enhancements in pharmacy education. And this important topic, which is also covered on the questions, the need of interprofessional collaboration. Thank you so much for all our speakers. Thank you so much for FIP for organizing this event. Please feel free to let us know what sort of topics you would like to cover on our next events. And hope you enjoy the rest of your day, afternoon, and night. I'm very much looking forward to see you on the next FIP event. Thank you so much.
Thank you. Bye.
Bye. Thank you.
Thank you all.